I am honored to introduce my colleague, Dr. Faiza Qari. She is a professor of medicine and endocrinology at King Abdulaziz University in Jeddah. And she is known to our community as very interested in treatment of diabetes. Please, Dr. Qari.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم أجمعين. I'm sure that everybody tired and get fed up and he wants to go home, especially me, from the morning. I will just try to make it easier, practical, in case scenario, rather than just a lot of data and a lot of research and like this. Try to make it so simple. Yes, please. Okay, so we know everybody talk about irhab. So what our irhab in medicine? So the most important irhab in our medicine actually is diabetes and hypertension. We start with like this. So why we said like this? Because we know that hypertension is usually associated in diabetes and is twice commoner in diabetic patients. The new onset diabetic patients, they have 2.5 times more commoner in hypertension. Around 40% of patients are pre-diabetic with impaired glucose tolerance test, they are hypertensive. 40% to 50% diabetic patients, usually they have a hypertension. Only, unfortunately, only quarter of those patients being controlled. We know if we have we have hypertension, diabetes, and etc., that increasing the cardiovascular risk. Usually diabetes lead to hypertension, hypertension lead to diabetes. If diabetes associated with hypertension, this will increase all the other comorbidity from neuropathy, from nephropathy, from retinopathy, stroke, which is most important thing as mentioned by Dr. Omar, coronary heart disease, and of course, mortality. So that's 40 to 80% of diabetic patients is usually they have hypertension. If they are diabetic, it's more likely twice commoner, twofold increase in the hypertension as being demonstrated in this slide. The problem of hypertension in diabetes that is mainly associated with systolic hypertension. Problem of systolic hypertension is one of important cardiovascular risk factors, and systolic hypertension is sometimes very difficult to control. The thing that the patients, if they are diabetic and they have hypertension, they get depressed. So the questions of compliance, it will be poor, and they don't want to take medication. One of important issue that I put it in yellow, that clinicians inertia. What is this clinical inertia? That we focus only on diabetes, and we don't look to the hypertension when patients come to our office, or just we underestimate it. Yeah, maybe next visit I will see the hypertension. I am scared, I am whatever. So we don't treat the patients with hypertension, just we concentrate on diabetes, and that will cause a problem in the future. Of course, there's a lot of studies, but the meta-analysis showed if we manage to reduce the blood pressures in diabetic patients, we manage to reduce the stroke, we manage to reduce the total mortality, we manage to reduce the cardiovascular events. So what is hypertension in 2018, as you mentioned? The most important thing, four important things. First, how to diagnose hypertension in diabetic patients when they come to the office. Before that, that's just we measure the blood pressures in the office. But now we don't say like this. We said either we do ambulatory blood pressures measurement, or the best way that patients, they measure blood pressures by this automated blood pressures measurement, and we can take reading, because by this way we avoid the white coat hypertension. So that's one important message that we have to keep it in our mind. Second, what targeting blood pressures we wanted in our patient, especially diabetic patient. So we take this scenario. What is going on now? Yes. So what's the result of blood pressures we wanted in our patient? So we start with simple scenario. We'll not go for details. So we have an old patient. Mr. Ali is more than 76. He's had myocardial infarctions. He's been hypertensive for quite a long time. His blood pressure is around 135/80. He's taking a lot of medications for controlling his blood pressures. His hemoglobin A1C is not bad. It's around 6.5. His cholesterol is being to the target, and we measured his blood pressures at the office, and we found it 135/80. Are we happy with these blood pressures? Yes or no? خلينا بس نصحصح شوية. Yes or no? So he's a diabetic. He has a cardiovascular risk. So usually, we go to the next. In those patients with a high risk, the patients, high-risk patients, they have already a cardiovascular problem. They are diabetic. We want to be strongly control the blood pressures. So our aim to reduce the blood pressures to 20 or less than 20 systolic and diastolic less than 80. This is a high-risk patient. And of course, if they are not a high-risk patient, we can accept more higher blood pressures, as you heard through the day. So in high-risk patients, in diabetic patients, we want our blood pressures to be strongly controlled, better to be less than 120 systolic and 180 diastolic. So for those patients, especially high-risk patients, especially if they age more than 50, if the systolic blood pressure is more than 130, try to reduce the blood pressures to 120. Of course, if when we do this one, is not happening without a price. So the price for those patients that they will be, this is an intensive management for those patients, and usually we advise those patients to have a blood pressure monitor at home so they measure it, and when we give them this many medication. So the guidelines according to this SPRINT study, which is a large and huge study, more than around 10,000 population. So they recommend that we have to do this intensive glucose targeting for the patient, intensive blood pressure monitoring for high-risk patients, especially if they have a cardiovascular problem, clinical or subclinical, and especially in diabetic patients, or even if they have a chronic kidney disease, either diabetic or non-diabetic, or if we estimate the cardiovascular risk factors in 10 years' time is more than or equal 15%, or if they are old. So this is the patients that we want an intensive management of blood pressures. Of course, by giving a lot of medications, what happens to the patient? They can have hypotension, they can have a renal deterioration, they can have a potassium abnormalities. So you have to spend time with patients telling them what is the benefit of intensive controlling the blood pressure, as well the other risk, and take the consent. Explain to your patients about intensive management for the hypertension. So according to there is how intensive therapy we wanted for our patients. Of course, there is limitations to or no evidence, but we have some evidence, especially in diabetic. I put it in the green. According to a Qari study, that if intensified hypertension management in our patient is not without a risk, and some of patients in this Qari study they die, but still the benefit is more. And there is, of course, is contraindicated in certain type of patients, but we'll concentrate in diabetic patients. So the message from this patients or from this scenario, that you have to choose your patient, especially diabetic patient, intensify your therapy, and we want the blood pressures to be controlled around less than 120/80. Of course, modified or controlled by automated blood pressures in the patients at home. So this is the first message. Second message, what types of medicine is better for those patients? Of course, for diabetic patient, ERB or AC inhibitor, but just if the patient he's taking, usually we don't use single medications, we use more than medicine. So if the patient is on thiazide diuretic, most of the medications combination therapy. We take this scenario. So Faiza is a 53 years old patient. He's a hypertensive. He's taking medication for a couple of years. He managed to lose some weight. His hemoglobin A1C is around 6.8, and his his blood pressures when he came is 130/20, but important thing that he's taking as medications, he's taking hydrochlorothiazide. Are we happy with this blood pressures, and are we happy with the medications? Any بس شوية عشان مندوخ ونصحصح على النهاية. Okay, so somehow we are happy about his blood pressures, lastly, 130/84. But what about hydrochlorothiazide? So now the long-acting thiazide diuretics like indamamide, اللي هو Natrelix, or short-acting hydrochlorothiazide. The best, of course, is the long-acting indamamide. We know that the thiazide, whatever thiazide, is good for patients. There's a lot of studies prove that it improves the cardiovascular mortality, improves the cerebrovascular accidents, improve the heart failure, and all-cause mortality. Seeing here that you're seeing by the long-acting, which is the gray one, is better controlling the blood pressures, and more important is reducing in cardiovascular mortality than the short-acting. So that's we try to shift the patients to the long-acting thiazide, aiming to reaching to in comparing to the short-acting. The third message or third clinical scenario that in any patients, especially diabetic patients, we talk about diabetic patients, when they come to our office, we try to use single pills combination, that one pill containing more than one medicine. We don't want to try to give patients. This is usually maybe in private hospital, we use single pill combination. Unfortunately, maybe in military hospital or National Guard hospital, they still they like the titration of medicine. But we'll see. So Mr. Muhammad is a 59-year-old patient. He's a diabetic, and he is, for the last 3 years, his blood pressure is around 146/92. His blood sugars is not bad. Hemoglobin A1C is around 6.8. His LDL is 3.9. He's taking a lot of medicine, but he's not a good compliance. And he asked you, what about the single bed treatment? So what antihypertensive would consider in these patients? Remind you again, diabetic, hypertensive for quite few years, and he is hypercholesteremia. Of course, any patients, the first-line recommendations for those patients, especially in diabetic, we want it tightly controlled. So we have this group of medicine from thiazide, diuretics, long-acting or short-acting, ACE inhibitor, ARB, calcium channel blockers, and beta blocker. So usually we combine therapy. And of course, in patients diabetic, we try to choose ACE inhibitor and ARB in that combinations, and we have a lot of combination. And that's an easy initial therapy. We don't want to have to wait and start one therapy and then another therapy, especially if the systolic blood pressure is more than 20 and diastolic more than 10 when he initially presented. But we try to avoid the beta blockers in patients above the age of 60. So single pill combination is the best for our patients, either in 2017 or 2018. So long-acting thiazide, like diuretics, preferred than short-acting thiazide. Beta blockers is not advisable for patients above the age of 60. The best, of course, especially for diabetic patients, angiotensin receptor inhibitor and calcium AC inhibitors. That's the best combination for those patients, and recommended single pill therapy in those patients, especially with diabetic. And we have a lot of combinations in the market. So, of course, AC and ARB is the best. We know why it is the best. Mentioned it how many times and during the day. Well tolerated. This side effect, reducing, most important, is reducing cardiovascular mortality and morbidity. And usually we have to be careful in certain types of patients, like patients with bilateral renal stenosis or severe renal impairment, or we have to watch the potassium very carefully. Some patients, they suffer from cough with AC inhibitor and angioedema, but it's a beautiful drug, and especially with combination. So the advantage of single pill therapy, combination therapy, that is associated with better compliance for our patients. The regimen featuring initial prescription of single pill combinations lead to better blood pressure control. Initial combination therapy, we have to keep in our mind to reduce the cardiovascular events than monotherapy. So there is two main great studies, which is mentioning that single pill combination, especially if we combine ACE inhibitor or ARB with calcium channel blockers plus or minus diuretic, is proved to be much better than just giving the patients many medicine. And this is study being published in New England Medical Journal, HOPE-3, as well another study which is as well published in a New England Medical Journal. So we'll just skip this slide. You can choose whatever if you have patients less than older or younger than patients with than 55, especially in diabetic patients, keeping in your mind that AC and ARB is one of important things that you have to put it in your choice of your medicine, especially single drug combination. So lastly, take-home message. 4 important take-home message. 1, depends on ambulatory blood pressure measurement for your patient. That is important. Don't rely on what you measure the blood pressures in the clinic. Second, if you can choose the long-acting diuretic for patients, is better for our patients, especially diabetic patients, and more control and more cardiovascular protection. Third important thing, that what targeting blood pressures we needed in diabetic patients. We wanted intensive control of blood pressure, aiming that prevent cardiovascular mortality as well renal deterioration. And fourth important thing, try to choose single pill therapy, keeping in your mind in these combinations in diabetic that containing ACE inhibitor and ARB. And I think that's finishing your day. Shukran.